What is a microdiscectomy? Microdiscectomy, commonly done in the lumbar spine, though it can be done in other parts of the spine as well, is essentially you're plucking out the piece of disc that has herniated through the outer casing. The best way for me to help a patient understand that is I often look at my Kleenex box and I point to it and say, you see the part of the Kleenex that's sticking out for you to grab? Essentially, that's what I do. I go in there and grab that portion that's sticking out and I pull the portion out, and that is the microdiscectomy. The rest of the disc remains in. We do go poke around in there to make sure there's no further unstable fragments that are looking to come out as soon as surgery is done, so that you're not a repeat offender or a re-herniator. So it's when a herniated disc is ruptured out of the Kleenex box, if you will, or the jelly out of the donut, and we're essentially plucking out the portion that is pushing on the nerve, which alleviates the tension on the nerve, and therefore that gives you that nerve pain relief, the sciatic relief that you're looking for. Microdiscectomy is often done for that horrible sciatic pain or the horrible shoulder and arm pain. It's described as numbness, tingling. Sometimes it feels like hot water or boiling oil being poured down along a specific nerve pattern known as a dermatome or a myotome. Similarly, for the sciatic symptoms, it starts off with back pain, severe spasms, feels like your back locks up, goes into your buttock area. So initially it starts off in the back or the neck, and then again, your buttock and your shoulder being the girdle areas, that's where it goes into. And as those symptoms progress, or as the nerve continues to be more and more irritated, you will have those symptoms go ahead and travel down your leg or travel down your arm. And therefore, that nerve is under a fair bit of tension. MRI being the gold standard of identifying this pathology will be required for us to go ahead and pinpoint where this herniation is. Older patients who have seen a fair bit of wear and tear in their life will see the same symptoms related to a bone spur. And the goal is simply going in there and plucking out the area or drilling out the area that's causing that nerve to be under that tension, alleviating that tension so you can get back to life. In my hands, the most efficient and most minimally invasive approach is an endoscopic approach to doing this. We go in, we pinpoint exactly where the pathology is. We correlate the MRI that we see in the office, and then when the patient is on the table, we go ahead and pinpoint exactly where that pathology is. So even our incisions aren't a generic gestalt over this specific area, meaning we're gonna make an incision between here and here because this is where this anatomic landmark exists, this anatomic landmark exists, and then we go to town with a soft tissue destruction to get to that area. Minimally invasive requires you to nail that incision down to near perfection so that when your camera goes in there, you can preserve the anatomy and not have to drill enough bone if you need to. You can get underneath the slab to fix something without having to tear apart the slab. For anyone who has had a slab issue or moisture problem underneath their house, they can understand how catastrophic and time-consuming and expensive that can be for their home. Similarly, I use the same example. I don't have to tear apart the slab in order to figure out what's going on underneath the slab in order to resolve the problem underneath your house. Similarly, I don't have to go ahead and create that havoc on your normal anatomy, meaning doing wide laminectomies, which is basically drilling out the bone so that I can enter the spinal canal. Once I enter the spinal canal with that same pinky size incision, I can get in and move the nerve aside, identify the disc herniation or identify the bony overgrowth or the bone spur, and specifically drill that out with exacting precision and leave the rest of the anatomy alone. Recovery timeline varies from person to person. I will always say the most motivated person will always do the best. Majority of my patients are prescribed 5 tablets of a prescription pain medication and a muscle relaxer versus dozens of pills for an open surgery. That being said, I will always hear patients say, all I needed was an ice pack and maybe 1 pill just to kind of help me turn my mind off the day of surgery. But oftentimes when we call patients in the evening, just to make sure if we can answer any further questions or address any concerns, they are always very emotional. Emotional because this is what pain-free feels like. And maybe a couple days worth of soreness, something that could be addressed with some Tylenol and ibuprofen. but we don't need narcotic pain medications that are highly addictive for soreness. Those who go to the gym don't come home and pop in a Vicodin afterwards, right? They're enjoying their life probably within a couple of days rather than several weeks. So if you're experiencing sciatic symptoms, definitely come by and see us. And if you've been told that you need surgery to address your sciatica, which is a herniated disc or stenosis, definitely come by and see us, see what we can offer that is different from the mainstream surgery. When patients understand the full gambit of options that we can offer them, they can make the most appropriate decision.